SIADH stands for Syndrome of Inappropriate ADH Secretion. Normally, low blood volume and high serum osmolarity stimulates the hypothalamus to produce ADH, which goes to the posterior pituitary gland and is then released into the bloodstream. ADH reaches the nephrons of the kidney via the bloodstream. Here, it acts on a specific part of the nephron known as the collecting duct. In the collecting duct are aquaporin II channels which reabsorb water. ADH stimulates production of more aquaporin II channels, causing more water reabsorption. This results in increased blood volume and decreased serum osmolarity. In SIADH, excess ADH causes more and more aquaporin II channels to form, increasing water reabsorption, resulting in higher blood volume and lower serum osmolarity. But the story doesn't end here, because now the heart gets involved. In response to increased blood volume and decreased serum osmolarity, the atria release atrial natriuretic peptide and B-type natriuretic peptide, ANP and BNP, which promote natriuresis in the kidney, the excretion of sodium into urine. And what follows sodium into the urine? Water. ANP and BNP also inhibit the renin-angiotensin-aldosterone system, which results in the same effect of natriuresis and water loss. So the overall effect of SIADH is euvolemia, as the high blood volume developed initially is brought back to normal by the loss of water into urine, hyponatremia, and high sodium in urine due to excretion of sodium into urine. These three characteristics are important for SIADH, so let's go back and add this to its definition. It is characterized by euvolemia, hyponatremia, and high sodium in urine. So what are the causes of SIADH? First, we'll mention those that affect the hypothalamus, which include trauma, surgery, and stroke. Some medications are also responsible for causing SIADH, such as chemotherapy, antidepressants, recreational drugs, diuretics, ACE inhibitors and SSRIs, sulfonylureas, and the hormone desmopressin. To help us remember them, we'll use the mnemonic CARDISH. Malignancies such as small cell lung cancer and pancreatic cancer can also cause SIADH. Nephrogenic SIADH occurs due to a mutation of aquaporin II channels that cause them to remain open. Finally, central nervous system infections and chest infections can also be a cause. What are the signs and symptoms of SIADH? Initially, the low sodium results in symptoms of dehydration such as headache, nausea, vomiting, confusion, and tremors. Later on, when the sodium levels drop even further, it causes more water to cross the blood-brain barrier, resulting in cerebral edema. This can lead to mood swings, hallucinations, and in severe cases, seizures and coma. Now, how do you diagnose SIADH? Keeping in mind the important characteristics, sodium levels in serum can be measured. The normal range for serum sodium is 135 to 145 milliequivalents per liter. Low sodium in the range of 125 to 135 milliequivalents per liter can account for initial symptoms, and severe hyponatremia is seen when sodium levels are less than 125 milliequivalents per liter. Sodium levels in the urine can also be measured, and in case of SIADH, they will be more than 20 millimoles per liter. The urine and plasma osmolality is also measured, and the ratio of urine to plasma osmolality should be greater than 1 to rule out renal dysfunction. Renal function tests, thyroid function tests, and cortisol levels are also done to rule out other causes of hyponatremia relating to kidney, thyroid, and adrenal glands. So how do we treat SIADH? The first rule is to make sure that you treat the cause, whether that be infections requiring antibiotics or malignancy requiring surgery. Next, we should restrict fluid intake in patients with SIADH to no more than 1 liter per day. This allows decrease in blood volume and increase in aldosterone, whose function is to reabsorb sodium from collecting tubules. Hypertonic saline infusions can also be given to replenish sodium. making sure that the infusion is given slowly and the maximum correction of sodium per day is 6 milliequivalents per liter. If sodium correction is done any faster, it causes the blood concentration to increase too quickly before the brain can adapt. As a result, water diffuses along the concentration gradient from the brain parenchyma into the blood, shrinking the brain parenchyma. This debilitating condition is known as central pontine myelinolysis. Finally, demeclocycline is an ADH receptor antagonist that may be used for treatment in its oral form. That should cover all you need to know about SIADH. My next video will be about diabetes insipidus. Hope you look forward to it. See you next time.